Hello everyone and welcome back to Desert Docs, a junior doctor's guide to Central Australia. This is a series all about the unique medicine and working life that comes with operating in Alice Springs and the greater Barkly region, whether that be Alice Springs Hospital, Tennant Creek Hospital or in primary care. I would like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Aranda people of Mantua. We recognise their custodianship and their continuing relationship with country and that we work on their stolen lands. My name is Dr. Indira Barrow and today I will be talking to Dr. James Dowler, Acting Head of Paediatrics at Alice Springs Hospital. Today we'll be touching on a range of infectious and post-infectious conditions that affect the paediatric population in Alice Springs, including post-streptococcal glomerulonephritis, otitis media and chronic suppurative lung disease. So hi James, would you like to introduce yourself to the listeners?
Hi Indira. I'm James. I'm a paediatrician in Alice Springs. I've been here for 9.5 years now, living here with my family. I've got too many kids. I have a beautiful wife who runs Dusty Divas in town, and we have been calling Alice Springs home at least for the last 5 or 6 years of our stay here.
It sounds like that's the common theme for most people. They come and stay a few years because it's so great to live here.
Absolutely.
So I might crack into it, James, and we can talk about the first condition, which is PSGN, post-streptococcal glomerulonephritis. There are so many things we could explore in this episode, but I thought this was something that I hadn't encountered before coming to Alice Springs. So definitely one of those conditions that might be new to new junior doctors coming to work at Alice Springs Hospital. So James, can you talk about the presentation and a bit later on the management of this type of condition and why it's so important to recognise it?
Yeah, absolutely. APSGN, so acute post-streptococcal glomerulonephritis, or often it can be an acute post-infectious glomerulonephritis if you don't know if it's streptococcus or not. The reason you don't see it anywhere else is because it's not really anywhere else. This is near and dear to my heart because I did an audit on it back in 2015 and basically spent a lot of my spare time looking at the data in Central Australia and comparing it to the data in Australia. They looked for 16 years in metropolitan Sydney to review their cases of post-streptococcal glomerulonephritis, and they found 32 cases. We looked for a 5-year period and we had over 60 cases. So that's like a metropolitan centre with millions of people in their catchment, and ours is a little centre, and we have more than 2,000 times, I think it is. We were over 300 per 100,000 and they were 0.3 per 100,000. So it's a disease here and not very many other places. It's a disease of poverty. It's a disease of skin sores and skin infections. And so what we usually see is kids presenting young, usually 4 to 5 years of age, but can be up to teenagehood. And they're presenting, the classical triad is with gross hematuria, hypertension and peripheral edema. The majority of the time you will only get 1 or 2 of these things. So we also do a screening program for kids. So if kids come in with skin sores or with visible skin sores, we always want to do a blood pressure and a urine analysis on them. I'll just talk briefly about what happens in APSGN. So in Central Australia, kids present to clinic or to hospital with their first skin infection at a median of 9 months of age. That means that they're getting a streptococcal burden really, really early on. And the more streptococcal burden that you have, the more likely you're going to come across a pathogenic, nephrogenic streptococcus, which then creates an inflammation process. When your body gets rid of it, creates complement, which deposits in your kidneys. That gets inflamed. You don't pee right, you get hypertension. It causes damage, you get blood in your urine, and everything kind of stems from that.
So I think classically the teaching is you might have a tonsillopharyngitis as your group A strep infection, but I am now aware that it's more derived from skin sores, or maybe we call it impetigo here, which is group A strep and Staph aureus classically. So if you're saying these children are presenting from 9 months old as the earliest, and they have quite a high risk of developing subsequent infections. What is the treatment for the acute infection, and what kind of prevention do we have?
So the treatment for the acute infection in community and in hospital is LA bicillin, so long-acting bicillin, or a short course of Bactrim, which is 3 days of Bactrim. They're both shown to be equally effective against impetigo. The benefit of LA bicillin, and this is kind of looking to the theory of public health, is that if you have a child with skin sores, you want to treat them. Skin sores are incredibly infectious. The fluid from them gets on bed sheets, which becomes infectious, gets on clothes, which becomes infectious, gets on other people and infects other people. The LA bicillin, in theory, gives coverage for approximately 28 days. And so while you treat a child with a skin sore with LA bicillin, you can then take public health measures to ensure that the family are treated, the clothes are washed, the sheets and linen are washed, the sores are covered, and so it becomes less of a public health infection risk. The reality is that that often doesn't happen anyway, and so we find that giving Bactrim makes people more likely to come to clinic because they're not getting a big fat needle in their bum, and it tastes okay, and it's just as effective. Group A strep is exquisitely sensitive to penicillin, IM, and oral. Why we don't give oral penicillin is because there's not great evidence, I think, that it hasn't been studied for oral penicillin. But in reality, there's no reason why oral penicillin would be a bad treatment for impetigo. You'd have to give it for a longer period of time. It isn't as palatable as something like Bactrim. I really appreciate that Bactrim is a very broad antibiotic to be giving something like Group A strep, which is sensitive, but you can treat it with a lot of other things. But for better or worse, that's where the evidence has gone, and that's the antibiotic that has been studied, and so that's why it's in the CARPA manual and it's what we use.
And just to explain to listeners, Bactrim, sulfamethoxazole, trimethoprim, and CARPA is our Central Australian medicine manual, if you will. So, James, in what kind of situation would we admit someone with PSGN? Is it always managed in primary care? When will we see this in the hospital? When would we admit someone to the hospital with PSGN?
That's a really good question, and we often ask ourselves that question in peds as well, because the majority of APSGNs won't be clinically significant. For every one clinically significant case, there's two that are subclinical. There's two aspects of this. One is that we admit for a number of reasons. We might admit because the kid is acutely unwell, in acute renal failure, puffy, hypertensive, high potassium. That's a lay down misère of why you might admit someone. We might have a borderline kid who has some blood in their urine, is borderline hypertensive, don't know if they've got APSGN or not, don't know what stage of the progression it is. Our general approach is to admit all children with APSGN. Whether all of them need to be admitted is probably not, but you don't know the trajectory of them. You don't know where they've started in their condition, if they're halfway through, if they're at the end, if they're at the start. The diagnosis is made by doing a C3 or C4, so looking at their complement factors. So if you don't admit them and you don't get a C3 and C4, you don't make an official diagnosis. It's a notifiable disease, so if you don't have an official diagnosis, you can't notify it. If there's enough notified, there's a public health response to it as well. So it's important to admit them to make sure that we get the diagnosis for a more community public health level response.
What would be the value of doing strep serology in these patients? Is it just complement that we are looking into, or?
Strep serology is a funny one because it's a part of the diagnosis. So again, you have to do it because without it, you can't diagnose APSGN. Much like rheumatic heart disease, it's not diagnosed unless you have evidence of a strep infection, except for when you've got Sydenham's chorea or other pathognomonic occurrences. So it's important for a diagnostic purpose. Strep serology otherwise is pretty useless, especially considering the burden of strep in community. I rarely see strep serology that's negative. It's almost an arbitrary thing that it's going to be positive due to the burden of skin disease.
So you've done your investigations, complement, strep serology, examination shows high blood pressure, clinical exam shows edema. I've read that the face is often affected. Moving on to symptomatic treatment,
Yep.
I imagine some of these patients would have an AKI. Are you giving these small children fluids in the hospital as well?
It's a balancing act as to what we do. At the end of the day, a PSGN should write itself. So we're only doing things that are supportive and preventing complications of the APSGN. So the big complications are hyperkalemia. So quite rapidly when children become anuric, their potassium rises. So managing hyperkalemia, preventing arrhythmias is incredibly important in children with APSGN. Fluid overload is the next one, and fluid overload leads to hypertension, and the kidney injury itself leads to hypertension, so we want to stop hypertensive encephalopathy. These aren't huge numbers of kids that end up with hypertensive encephalopathy or severe hyperkalemia, but it's enough that we need to screen all the kids who have APSGN frequently with bloods and make sure we know the trajectory of their condition. And then lastly, it's some symptomatic relief. So it's not comfortable being 2 litres fluid overloaded, and so we provide symptomatic relief with furosemide. It's rare that we give kids fluids. If we give kids fluids, it's because we've over-diuresed them. So we'll put children on a fluid restriction, usually half to 2/3 their maintenance, and we will hit them with some diuretic to try and get the extra fluid off. There's lots of nuance to it though, because a lot of kids, they come in and they're uremic, and they're feeling terrible. And so they've actually been vomiting for the last couple of days. So they're actually managing their own fluid balance very well by not drinking, vomiting up some hydrogen to keep their potassium down as well.
And is there a role for antihypertensives in this setting as well?
Yes, so we treat acutely with antihypertensives. If we have a normovolemic child who's still hypertensive, we'll give them a calcium channel blocker usually. Sometimes the hypertension persists and we can put them on a longer acting, usually calcium channel blocker still.
Let's say we've done all that and we are feeling very proud of ourselves as doctors in the hospital. What is the long-term sequelae of having PSGN? What are we really worried about, and what kind of monitoring is important for these kids?
Yeah, often these kids just disappear into the ether once they're well, which is one of our biggest challenges. When I did my audit, it showed that kids wouldn't get follow-up for, I think the highest was over 2,000 days that they didn't get into their next follow-up. But at least they did get follow-up. There are a lot of kids that didn't get any follow-up whatsoever. The 2 things that we really want to make sure is, one, it was actually APSGN. So without a biopsy, it's all assumed that that's what it is. But as a lot of clinicians in Central Australia know, lupus is everywhere. And so we want to make sure that the complements come back up to normal. So we repeat bloods, including complements, 6 weeks later at a minimum. And if they haven't come up to normal, it raises kind of alarm bells that maybe it's lupus, maybe it's another autoimmune condition that's caused it. And that's the main reason why we do follow up from that aspect. Looking more long term, it used to be thought, and generally it still is thought, that an episode of APSGN is not going to cause kidney damage long term. That's not the way the evidence is leaning at the moment. What we see now is that it's one hit in what can be many hits that leads along the long and winding road to dialysis and renal failure. The other ones we see are lots of type 2 diabetes and, interestingly, IUGR, so that's small babies or babies born less than 2.5 kilos. If you have that and you have an episode of APSGN, you're incredibly likely to end up on a pathway towards renal failure.
And something we see all the time in Alice Springs, there will be other episodes of Desert Docs that talks about chronic kidney disease and dialysis. If I can change to our next topic, James,
Sure.
We have otitis media. Otitis media, as I understand, is a broad umbrella term for the range of ear conditions: acute otitis media with effusion, and chronic suppurative otitis media. Are you able to detangle otitis media?
Possibly. So first, with acute otitis media, it's an acute infection of the middle ear. Incredibly more common in children in Central Australia and predominantly Indigenous children. It's not perforated, it's a painful ear, it's an acute onset ear. You always treat that with oral antibiotics in our Indigenous population. And the reason we treat that is to prevent perforation. That's where the evidence lies. It doesn't necessarily make the pain better. It doesn't necessarily make the infection go away. It reduces the rate of tympanic membrane perforation. When that pops, It's acute otitis media with perforation, and so you do get discharge, but that discharge is short-term discharge and, again, gets treated with oral antibiotics. If the discharge lasts for 2 weeks, then that's when it becomes chronic suppurative otitis media. And then from that point on, any discharging ear is chronic suppurative otitis media. What often happens is that I will see a child with a discharging ear with an unclear history beforehand. As a general blanket rule, I will call it chronic suppurative otitis media just based on risk stratification, and then treat it more aggressively. The other thing that happens is that you can have a chronic perforation and then discharge from that perforation, which isn't infectious discharge. So if you've got a hole in your ear and you get a cold, then you're going to get mucus coming out of that ear, and that's can be normal. So if it's not purulent, then it's not necessarily infected. It can just be a wet ear. Similarly, that's what happens with grommets. People get grommets in, and then the parents are like, oh my gosh, there's all this stuff coming out of the ear. It's like, yep, that's what the grommets do. They let stuff leak out of the ear. And so you can get that. So the kind of time course we're looking at for this is that once kids are 5, 6, 7, 8, they usually stop getting suppurative otitis media. They stop getting runny ears, and they end up with dry, large, or small, but often large perforations in their ear. The reason it stops at that age is because their eustachian tubes get bigger, the drainage is better, they're less exposed to infections because they're not, licking things, putting things in their mouths, snotting on each other. So at that point, with a dry perforation, that's when we can intervene with ear, nose and throat surgery. And by we, I don't mean me. You can have laryngoplasty, where they will repair the ear. Before then, it's not really prudent to have ENT involvement from a surgical perspective, because you can heal the ear. You can, put a slap of skin over it and create a new tympanic membrane. But the moment that you get another infection, it's just going to pop again, and you'll have a failed laryngoplasty, which is usually the case up until 9, 10. ENT won't do that.
Yeah, okay. And is there a role for ENT to put in grommets in that time frame where they're still getting recurrent acute otitis media infections?
It's complicated. So yes, it can be beneficial if you're getting recurrent acute otitis media without perforation. If you've got a perforation, the perforation is doing the job that a grommet would do. A grommet's just a tube that creates a hole in the ear. And if you've got a hole there that's draining it, there's no point in putting a grommet in there specifically. So having recurrent acute otitis media, or having otitis media with effusion, so the glue ear, we call it, where it's just a chronic build-up of mucus causing dull hearing, and they test that through audiology. So they send air vibrations and see how much the tympanic membrane wobbles, and if it doesn't wobble in the right way, they'll say that it's because of a fluid build-up behind the ear. If that occurs for 6 months, then it can be an indication for grommets, especially if there's a speech and language delay along with that as well. There's a lot of acute otitis media in community. What we see in the nasopharynx and the eustachian tubes in Indigenous children is that they're 50% more likely to have pathogenic bacteria there. And so with any kind of blockage, so you have a cold, you have an upper respiratory tract infection, you're more likely to be hoarding pathogenic bacteria in your middle ear, and then you're more likely to have a significant bacterial otitis media versus a child in the suburbs of Sydney where they have less pathogenic flora in their oropharynx, where they also are exposed to less infections and less bacteria. They're more likely to just have a middle ear infusion like a glue ear, where there's mucus, but it's not infected mucus kind of stuck behind their ear. So that's the primary reason we're more aggressive with treating acute otitis media. There's a lot of treatment with antibiotics for earaches in community. The huge burden of upper respiratory tract infections and the pathogenic bacteria in the ear canal and nasopharynx will lead a number of children to having chronic suppurative ears that don't heal. The intervention, I do not believe, is necessarily a medical intervention that's going to fix that. I think that we do try and improve things. And when I speak about improvement, I know a lot of the time that the child might have recurrent episodes of chronic ear discharge or might have recurrent episodes of acute otitis media. What I want is for the ear to be clean and clear for as long as possible. And the reason for that is hearing. So you have, firstly, more exposure to normal hearing, or as normal hearing as children can have if they have holes in their ears. And secondly, more ability of the body to heal and to not have chronic scarification of the tympanic membrane. It's an incredibly difficult space because, much like skin sores, and I kind of clump all of these together as diseases of poverty, the underlying issue is to do with bacterial burden and to do with overcrowding and social determinants of health, which are the majority of the time out of our control. Unfortunately, the prevalence is so high that it doesn't register for community members. It doesn't necessarily even register for clinics as well. So to have a child come in with skin sores and chronic suppurative otitis media and runny ears, it may not be one of the priorities of mum bringing child into the clinic, and it may not be one of the priorities of the remote area nurse who's seeing the child and maybe seeing them for a different reason, because they're wheezy or because they're coughing or because they've got a boil on their bottom or something like that. So often it is neglected to the point that it's really difficult from a medical perspective when we see them, certainly as paediatricians. We're not primary healthcare physicians, so we see them as they've got this and they've got chronic suppurative otitis media. There's no space there where we can jump in and say, a course of amoxicillin here is going to cure the problem. It's really just management and Band-Aid intervention. Yeah, which is difficult, but one of the most important things about education around this, whether it's to the mums or to the kids themselves or to the clinic, is to make sure that they know that it's not normal to have skin sores. It's not normal for the ears to be runny, and that they need to go to the clinic with that problem if that happens, and they need to do the intervention as soon as they notice it. An intervention for chronic suppurative otitis media is really quite easy and ridiculous. Like, it is twice a day ear drops and, more importantly, ear toilets, getting the pus out of the ear. And that's a tissue spear. You literally just roll up a bit of tissue and stick it in a kid's ear and leave it for 2 minutes and then pull it out and see what's attached to it. We know that hearing is such a huge issue in the Indigenous community. We know that language development and all those things that stem from having adequate hearing and adequate speech can be challenging in the developmental space as well. So there's lots of effort in audiology. There's lots of effort in antibiotic treatment. There's lots of effort in managing the infection, but it's not the solution to the problem.
I think we have somehow disentangled the range of otitis media conditions.
I think I actually tangled myself up a little bit more. I'm going to go home a bit more confused and have to Wikipedia things again.
There is a really good resource online, which is otitismediaguidelines.com, if anyone wants to further read about otitis media in Central Australia. One
of the great things you can do, like in peds in general, much like listening to hearts, you have to listen to 1,000 kids' hearts before you get the rhythm right and can hear murmurs and things like that, because they just go fast. You need to look in 1,000 kids' ears and see what normal looks like and what different variations of abnormal there are. Similarly with skin, you have to look at 1 million skin sores, because it builds up your paediatric skills. So
I think the key is just to always look in the ears.
Yeah, it's the window to the lungs.
And speaking of lungs, that's a beautiful segue to our last condition, which is chronic suppurative lung disease. Now, this is something I had never heard of before coming to Alice Springs. As a junior doctor working in ED, I've noticed children with past medical histories of pneumonia a couple times and not thought anything further of it. Now I understand through a quick read of CSLD that if a child has 2 or more episodes of X-ray proven pneumonia, they are highly likely to have a diagnosis of bronchiectasis or chronic suppurative lung disease. Are these two conditions the same? How prevalent is this issue in Alice Springs? And what is the importance of diagnosing and managing this?
They're all very good questions. I'll start at the end with bronchiectasis and just kind of give a little narrative story about how this has all come about. Because similarly, I was an advanced trainee in paediatrics, general peds, when I came here. And I hadn't, I'd heard of bronchiectasis. That's something that old emphysemic people had generally, who smoked or people with CF had. But I hadn't seen very much in children. And CSLD, I also hadn't heard of it, even as an advanced trainee coming here. Starting with bronchiectasis, rheumatic heart disease, and kidney failure are like the health gap when I think about the health gap in Indigenous health. Those things all have a life expectancy around 42 years of age, which, in itself is just, catastrophic. Bronchiectasis was primarily seen as a disease of adults. And then when they looked into it, they found that over 80% of adults in Central Australia with bronchiectasis, the trajectory of their lung disease could be traced back to very early childhood. So this then goes to the oropharynx having a higher rate of pathogenic flora in it in Central Australia in Indigenous children due to overcrowding, due to social determinants of health. When children in metropolitan centres in, the eastern suburbs of Adelaide get a viral lower respiratory tract infection, they cough, they splutter, they microaspirate. They probably microaspirate saliva and normal flora, and it doesn't cause any problems. When children in Central Australia have the same, firstly, they're more likely to get it more frequently because they have more exposure to viruses because of overcrowding conditions. They're more likely to be smaller, IUGR, have other chronic health issues. They're more likely to have other general health issues, such as other infections, gastro, skin disease, which their bodies are fighting off. And subsequently, when they do present with a bronchiolitis or a pneumonitis, a lower respiratory viral infection, they are much more likely to aspirate pathogenic bacteria. And what we often see is children coming in with viral infections that can more likely turn into bacterial infections and turn into pneumonias or create a different type of trauma to the lungs. So what would happen usually, again, in a well child who has different social determinants of health and different demographics, is that you have a bronchiolitis, you cough for 1 week, maybe 2 weeks, and then you get better. And then you probably get another virus from childcare or something, but you get fully better. What we see in our children locally here is that they have a viral infection, they cough for 1 week, they cough for 2 weeks, and then the cough just continues. And it continues because of that now colonization of pathogenic bacteria down into the lungs. If that stays for 4 weeks, we call it persistent bacterial bronchitis. We treat it with antibiotics. We try and get all of our children who come into hospital and are admitted to have a GP review at 2 to 4 weeks to make sure that their cough is gone. At discharge, we tell all of the children, they don't listen very well because usually they're under 1. So we tell the parents as well that they need to go to their clinic if the cough hasn't gone after 2 weeks because they have to get antibiotics. And this is for viral infections. And so that's persistent bacterial bronchitis. If you get persistent bacterial bronchitis more than once, we call it chronic suppurative lung disease. If you have pneumonia more than twice in your lifetime, we call it chronic suppurative lung disease. And if you have lower respiratory tract infection that isn't chest x-ray proven, but you have 2 in the course of a year or 3 ever as a child, we call it chronic suppurative lung disease. And the kind of idea around chronic suppurative lung disease is that you have colonization of your respiratory tree with pathogenic bacteria, which is causing a wet cough. And that's chronic, and we start the children then on long-term antibiotics, so azithromycin, 30 milligrams per kilogram once a week for 6 months. And any wet cough we treat very aggressively. With Augmentin, we start with a 2-week course. We can stretch it to a 4-week course. Usually when you hit 4 weeks of a wet cough, we'll bring you into hospital and give you 2 weeks of ceftriaxone. That's chronic suppurative lung disease. The difference between that and bronchiectasis is a CT scan that shows bronchiectasis. So in theory, they're exactly the same thing. One's just radiologically proven and the other one's not radiologically proven. This intervention and treating this so aggressively has only really come across in the last 7 to 8 years, and only seen really good uptake in community over that period of time as well. So one of the things in PEDS is that we don't know. We don't know how well we're doing with these things, because the end goal is to stop adults from dying from bronchiectasis, but we don't see that immediately, and we'll probably never see that. It'll just be the different data that hopefully comes out in 20 years' time that show that admissions for bronchiectasis are decreasing. The azithromycin is really important. There's great evidence to show that it reduces hospital admissions and reduces pneumonia. And anecdotally, you know that when a kid with CSLD comes in, the more likely than not, they'll tell you that they've missed their last 2 doses of azithromycin, and that's then why they've come in.
And I imagine you might be having the same child on once a week azithromycin that also gets their once a month LA bicillin.
Yep.
And it's a high burden of disease for the child at such a young age and the whole family who's probably coming along to these appointments as well.
Yeah, it's incredibly difficult. And one of the things that we find in PEDS is it's difficult to prioritise different health management. We see it more in adolescents as well. So children, their exposure to clinic and their exposure to hospital is very traumatic. So you can understand a child who has skin sores not wanting to come into clinic because they're going to get a needle full of toothpaste in their bum, basically, which is what LA bicillin looks like. And culturally, there's a significant aspect in Indigenous culture of paediatric autonomy. So the children are autonomous. If they don't want to come into clinic, no one should make them come into clinic. And so most children are going to say no when they have the option of coming into clinic and getting immunisations, getting LA bicillin. And it all adds up as well. So not only that, they'll get a finger prick to check their hemoglobin levels. Their hemoglobin will be borderline. They'll get an iron needle. They'll get albendazole for worming if their iron's like it's a traumatic experience going into clinic. It's not a nice thing for a child. And it's a real challenge from that point of view to when the burden of disease is so high to balance out, okay, how many needles do we want to give this child in one go? How kind of cruel can we be, to be kind? And then similarly, when we go into the adolescent realm, we are seeing horrendous type 2 diabetes in young people and adolescents, and we have to decide, okay, do we prioritise treating your rheumatic heart disease with LA bicillin, or do we prioritise trying to get you to somehow swallow the metformin tablets, or do we prioritise insulin because you might have that and not have the metformin? It's really difficult to have a positive experience whenever you come to clinic. Everyone wants to jump on to you and jab you with needles and treat all your ailments, which you may actually consider as a relatively normal part of life as well.
And might not be having any symptoms of at that stage
absolutely.
as well. Yeah, I can understand that. James, it was lovely to talk to you today. It's been really eye-opening to disentangle a lot of those conditions, and I can definitely take away some of those things for my next rotation in ED, and I hope it helps other junior doctors. I just wanted to ask you a final question about what you love about working in Alice Springs. We've talked about a lot of the difficult trials and tribulations that come with such a high burden of disease in our paediatric population. What brings you back to work every day, and what do you like so much about working here?
There's lots of aspects that I like about working here. There's lots of lifestyle aspects that I won't specifically get into, but it is nice not to have a commute and have a lot of flexibility. For the specific work aspects of it, seeing pathology and managing interesting pathology is really rewarding here, in the sense that it is so incredibly broad. Like today, we talked about CSLD and bronchiectasis, where in our referral hospital, that's managed by the respiratory physicians. We talked about APSGN, which again, our referral hospital is managed by the renal physicians. Oh, and we talked about ENT, of which, the pathology here is, quite significant. And similarly, like, we have kids who have transplants who we manage here. We have, very sick neonates who we manage here. And so just the absolute breadth and scope of work is second to none, and you wouldn't get it from anywhere else.
Thank you so much, James. And thanks everyone for tuning in to Desert Docs. Desert Docs, a junior doctor's guide to Central Australia, is an NT Health Media podcast produced with the help of ACCC Studio.